Assalamu alaikum and welcome to this EUS course. It's a pleasure for me and I'm sure for the rest of the faculty to be here. And honestly, even though there's the jet lag and the tiredness that goes with these things, this was one of the features that after the course last year I was looking forward to for this year. So it's a pleasure and an honor to be in Pakistan always, and to be able to contribute in some way to the continued growth of endoscopy with all the excellent effort being done. So without further delay, I'll just get going here. So I thought I'd talk about a bit of basic principles of ultrasound, and Bhavi's here. She's a radiologist, so please feel free to correct me. My feelings will not be hurt. But in terms of ultrasound, I mean, we should all have some idea of what's what. And ultrasound basically is high frequency sound waves beyond what we can appreciate with our auditory system. So sound waves that we can hear are in this low 20 to 20,000 hertz frequency. But as you increase the frequency of the waves, they become very tight, compacted together. And in that range of 2 to 20 megahertz is where ultrasound in medical fields is used. And how is it generated? So you have these piezoelectric crystals that, once stimulated with an electrical current, create vibrations, and those transmitted vibrations are turned into an ultrasound signal. Basically, as that signal hits a structure, those are either reflected back or absorbed, or they go through, and based on based on what's reflected back is what we get as our ultrasound coming back, and that's converted back into an electric signal. So you've closed the loop, and that's how you create the image. And I'll get into that a bit more. There's some basic principles that are important to understand because they have an influence on your image quality. So reflection simply obviously means, this is physics, and I'm not a physics expert, of course, but you have an incident wave hits the surface and it gets reflected back. So that's your reflection. The more resistance or impedance there is, the less will get transmitted through, and depending on the characteristics, will get reflected back. What doesn't get reflected may create a signal, and things that are transmitted through around it will basically keep going through. So the area that is not letting anything through may cause shattering because you don't see those waves coming through. And we'll get into that. For a signal to be reflected, the ideal angle is 90 degrees, so perpendicular to the source. Anything that is off that angle, you will get instead of reflection, you'll get refraction. So those signals have an implication for causing artifact. So what you see at an angle head-on would be good, but then you'll get artifact being created because of the ultrasound probe not being in the right plane. So that's an important signal to concept to understand how we get false positives. We get false positives whether that's stone, whether that's a mass lesion, because air can oftentimes confound things, and reverberations where the ultrasound signal gets reflected back can also cause these problems. A few other concepts to understand would be scatter. So scatter basically is the amount of signal that gets distributed instead of being reflected once the ultrasound wave hits something. So here's the ultrasound wave being initiated. Here's your lesion of interest. As it comes and approaches that lesion, the wave of interest will come through. Some will reflect back. Some will penetrate through and go through. And then you have refraction as well as scatter all over. So based on within a structure, so within the pancreas, for example, you have fluid, you have solid protein, you have fat. Each individual component will have a different amount of scatter. And the cumulative result of that coming back will give you the different densities that will then give you what's called the echotexture of that organ or structure of interest. So that's why a solid lesion doesn't look all black. because there are different molecules in there that have different signal characteristics, and those come back and can be described as the echo texture. Then the issue is, so how does this actually work? So in simple terms, when you get an ultrasound image, you would get waves back, but waves would be not very useful for us in terms of identifying structures. So that's called the A mode. The sophistication of any ultrasound machine is to convert those waves into a bright signal, which becomes your object of interest. So we will often, if you're stuck in EUS, you don't know what's going on, you hit a button, you're getting vascular flow and your quality doesn't look good. If you just hit the B mode button, which is usually that big red round dial, and I'll come to that in a minute, that takes you back to the default mode, and you can look at your object of interest. So this is how it works in terms of actual visualization. The B mode allows you, so here's a transducer, it's transmitting a signal. This is the signal path, and you have different structures at different distances from the transducer, creating A mode just waveforms. These are useless for visualization, and in B mode they will actually create the signal will be converted into an image. And as your transducer moves along the structure of interest, those changes in the B signal will be transmitted. The other concept that is important to understand is the gain, which is basically, in simple terms, the strength of your ultrasound signal. So depending on how good the image quality is that you're producing, you may have to use more energy, ultrasound energy, to visualize, or you may be getting too bright an image, so you may have to turn down the gain, which is the round dial, which we'll come to as we go through this. So gain is an important feature for the strength of the ultrasound brightness. So just an extension of that is that what happens is, as ultrasound signal weakens as it penetrates tissue, and that's known as attenuation. So we can use the gain to increase the overall strength of the signal, but then depending on the unit you have, there will be either these external micro sort of adjustment calibers to make the gain at any particular level stronger or weaker, depending on which way you go. They may either be like separate dials for these, or they may be part of your LCD display, and you can select the appropriate setting, and you can adjust accordingly. Sometimes you want to keep the gain closer to brighter, closer to the probe, so you'll be towards the top end, and as you get away from the probe, it'll be towards the bottom end. And these have different terms based on the unit that you have in the Olympus system. It's called the STC, spatial time compensation. And then finally, resolution is, I think, an important concept. This you could think of as like a focus in a camera. So basically, the XL resolution is the ability to differentiate between two different target lesions that are in the same plane. So your ultrasound wave is coming through. The poorer the resolution, the image, the blurrier the image, they become merged. The higher the resolution, the easier it is for it to become separated into two separate lesions. So the importance of this is that as you increase the frequency of your ultrasound wave, the resolution improves. So the waves are more tighter together, so your signal is much more accurate. The flip side of that is that your ability to get depth of the lesion reduces. So our usual frequencies are in the order of 5 to 20 megahertz. The 20 megahertz is really just in the mini probe, which gives you very high resolution at very short distances, up to 2 centimeters. But the linear endoscopic ultrasound that we typically use, depending on the scope, will be 7.5 to 10 megahertz. Used to be in the 5 range, but now it's 7. And you get good penetration to about 4 or 5 centimeters quite easily with the current technology. And so that's, if you go across, what about separating side by side? And for there you have lateral resolution, and that's more a feature of the ultrasound probe, as well as some other things that we don't generally adjust for. Those are more constants in our practice. So those are just some basic principles. The final one I'd like to just touch upon is the Doppler flow, because we use that to identify vessels. So as opposed to your ultrasound image, Doppler is best seen when it's not at 90 degrees. If your probe is at 90 degrees to a blood vessel, you turn on your Doppler flow, you actually don't see anything, because Doppler relies on reflection. So, reflection of at a different angle, as the subject goes from one area to the next, that angle that is created allows you to see what the directionality is. So Doppler flow allows basically to see the directionality as well as flow within a structure. And there are different types of flows. The key point being that you can assess the waveform to separate arteries from veins, and you can, when you basically mix the B mode, which is your image, with Doppler flow, then you get duplex scanning, which is just like, all our lives in medical training, we've read these terms, and honestly, before I created this talk, I was like, what's Doppler and duplex are pretty much the same. Doppler on, Doppler off, who knows what the difference is. But when you start understanding it, it makes more sense, and you're like, oh man, I should have done this 10 years ago. So that's that. So coming back to the equipment now, so this is where the knobs and all come in. It depends on the units. I don't know if we have any standalone units in Pakistan currently or not. Okay.
But other than that, I'm not sure.
Okay, yeah.
I know that Shaukat Khanam had the
F-75, okay, yeah. So I currently have this. I know Khalid, and we had this discussion last year. Khalid prefers the ME2, I believe, or do you?
Yeah.
Yeah, you like the smaller standalone unit, yeah.
Very expensive machine, which is not.
Yeah.
And actually, EUME2 is unlike that.
Yeah, you like that, yeah.
It's expensive and doesn't have a job.
Okay.
I usually try not to go into that.
The F-70. I actually really like the machine, to be honest.
And you can actually, EUME2, if you take the extras out, which is, elastography, etc.,
Yes.
which, to be honest, for a regular practice is almost not needed. The cost comes down even more.
Yeah, yeah.
So I think we got the premium plus thing for the first time. You also had that. But realistically, I think, if I had, after that, now I would never get that, because after, getting all that, you really, for research centers and for, centers of excellence like yours, it's fine.
Yeah.
For standard EUS practice, I don't think you need that. It doesn't actually help. I don't.
Yeah, no, I'll just say that I personally do not use elastography. I know that you're a strong proponent of it and you like it, but
I strongly believe elastography only works in UK, not in Europe. It does not work outside.
it doesn't. It definitely doesn't cross the Atlantic. It didn't cross. It didn't cross over the Atlantic. But I know that I know you feel strongly about it, so I felt it was fair to give you at least an opportunity to. We break them down into very simple things by the time they get to the Atlantic. So
the message to the audience is just have a fancy technique, and since it's a fancy technique, we don't know the life of this particular thing. So let's let these three guys debate amongst themselves.
Yeah.
What's the exact place of this elastography? But for us Pakistanis, I think elastography is still in its development phase.
Yeah.
And we need to concentrate on the main black and white images.
Absolutely. Yeah, and I think.
The same thing is with the contrast too. So
Yeah. Yeah, and I.
That's why I said center of excellence, and research centers and centers that excel in EUS. I think it makes sense to have that, but for centers that are actually developing EUS services, I find the role is almost non-existent or very limited, but the cost is there. So you can actually cut down the cost of the equipment if you don't take those.
Yeah. I mean, they will always try and upsell, right? So they'll say
Yeah, they
you,
will
you can
provide
add you can add this and it adds, you can differentiate. But reality, I'll just give you a practical sort of approach that I have, that if my suspicion for a tumor is high enough, then I'm going to have to biopsy. So I understand the role of elastography to maybe biopsy, maybe not. It's being defined. Yeah, yeah, exactly. But in in my it hasn't taken up in America. I'll just put it that way, and it just did
The
not.
reason I raise this point is because some of you are going to be involved in purchasing your equipment.
Yes,
And I
yeah,
think, if you can bring down the cost if you, because the company comes and says, wow, you should also have this, you should also have this. And obviously when we are not experienced, we don't know, and say, well, let's take the top of the ring then. I mean, we're only going to buy once. So that is why I raised this point. So if you're involved in buying, I think, you need to take a step back and see whether it's worth spending money on that, or you want to spend something else. And then when you develop the service and you're going towards a sort of excellence, then maybe, you can add.
yeah.
Can I just ask for the gas? So how much does it cost each modality?
Oh, the difference is about $40,000
Between the
overall.
So for the cost.
So you will save about $30,000 to $40,000 not having those.
Each modality.
No, not each.
As a
They come
combined.
as a.
So for us.
So it's a premium plus. And premium plus will give you all those. Will give you contrast. I mean, we have contrast, elastography, and everything else. And so when we were buying, to be honest, the reason why I brought this up was I had no one. I went and I saw and I said, that what they have period here. Why would I didn't even know much. So that is why I said and since then I've been involved in 3 equipments in Pakistan, and all 3 don't have that.
Yeah, so I use elastography only to make sure the equipment is still working. Just check it like you do at home.
Yeah, I mean, I don't feel too strongly. I don't think it's reached the threshold where it has truly been shown to make a significant difference that one would say, you know what, it's not right for us not to have it. I think it's become an optional thing that may add, may not add, but I will add that.
May I just say that, guys, you have excellent centers. Continue having the best equipment.
Yeah.
Would guide us onto economical good practice EUS.
लेकिन मैं एक चीज़ जो लोग पब्लिक इंस्टीट्यूट से आए हैं उनकी जो परचेजिंग प्रोसेस है थोड़े से डिफरेंट होते हैं. Saad is right in saying that we have to compare and we have to do the cost cutting. But let me tell you, in the public sector, when we have to buy certain things, तो होता है कि let's suppose कि 3 vendors हैं. 3 vendors ने जब अपने इक्विपमेंट को पेश किया तो गो के टेक्निकल स्पेक्स टेक्निकल बंदे नहीं फ्लोट करनी होती, लेकिन जो टेक्निकल कंपैरेटिव शीट बनती है वो बनती है एक बंदा जिसको कहते हैं टेक्निकल ऑफिसर, which is biomedical engineer who is non-technical in terms of medical science, and he has done just the BSc biomedical sciences. तो वो जो कंपैरेटिव शीट बनाता है तो वो बनाता है जो चीज़ें कंपनी ने अपनी हाईलाइट की होती है. तो वहाँ पे जो साथ साहब ने बात की है वो एट टाइम्स वो काम नहीं करती. तो जिनका पब्लिक मेडिकल कॉलेज का बैकग्राउंड है उनमें थोड़ा सा मे बी इसका कैवेट हो, क्योंकि वहाँ पे जो टेक्निकल ऑफिसर वो मे बी ऐसे इक्विपमेंट को एज दे दे जिसकी प्राइस मे बी कम हो या जिसकी क्वालिटी कम हो, लेकिन उसमें उसने ये चीज़ें हाईलाइट की हों, इलास्टोग्राफी और ये भी चीज़. तो अपनी जो टेक्निकल शीट बनाएगा उसमें कह देगा कि जी एक्स कंपनी ने जो मॉडल कोड किया उसमें एडवांस फीचर्स नहीं हैं, वाई कंपनी ने जो मॉडल कोड किया उसमें तमाम फीचर्स हैं, तो सो दिस कंपनी इज़ बेटर एज़ कम्पेयर टू द एक्स कंपनी. तो इस चीज़ को आप जब डिसीजन मेकिंग में होंगे तो उसको भी ख़ास तौर पर ज़हन में रखिएगा.
बिल्कुल, क्योंकि आई थिंक एज आई शो यू कि देयर आर डिफरेंसेस इन द स्कोप्स, और अगर आपको एक डील बेहतर मिल रही है बट देन यू कॉम्प्रोमाइज ऑन द स्कोप, दैट इज़ अ मच बिगर इशू इन माई माइंड. Anyway, so moving on, the one advantage of these small units is that they can become part of your endoscopy cart, so that you don't have to haul a big unit for cases. So portability becomes easy. So because we're going to talk mainly, we're going to be working with the EUME2 by Olympus. So this is basically, I apologize for the crude pictures, but I took these. Uh, um, this is your working panel. So these are the key areas that you will be constantly working with and need to be very familiar with. And we'll go through some of those sort of panel buttons. So the first thing is image. When you first start, image freeze and unfreeze to get your ultrasound image going or stopping it from working. So that's the first button usually that everybody needs to be aware of. If you say that you've done 20 and you don't know the freeze button, then I'm not sure if you've done 20. So everybody should know that. But that just allows you to check your image. Secondly, the depth range allows you to see, and these, it's not, this is just to introduce these buttons. We'll go through these during the course. Allows you, like we were discussing, how far the ultrasound image should go out for you to sort of focus on the area of interest. So if your lesion is far out, then you want your to be able to look further out, and then if it's closer by, you may not need to look far out. You can actually reduce your depth of image and focus in your area. My personal preference is actually not to be too magged out. I actually like to be relatively close to my area of interest, such as the pancreas or lymph nodes. I don't like to have a very big field I want to be focusing. When I want to take a global look of the entire organ, that's one thing, but when I want my tumor, then I want to get closer in. So, and we'll go over all these when we do the cases. So the gain is, again, the strength of your ultrasound, the brightness, and its default is 12 on the ME2, and you'll have that reading up in the left-hand corner, and you can adjust it. If you think that the image is too dark, you increase the gain. You increase the gain, and if it's too bright, you reduce the gain. So that's basically it. And then you have the STC function to individualize the gain, and that isn't on your main screen. You have to hit image adjust, then you get the STC, then you get the menu, and then you can make these adjustments. One thing about EUS is that a lot of the theory makes no sense until you're actually in the case at doing and playing with these things. So the other thing you can do is actually change the contrast, the difference between black and white in an image. And that value is defaulted at 5, but you can go up and down on the contrast. So just to give some examples, too bright an image, the gain is too high, so you can reduce the gain. You lower the gain and the image becomes better. Higher frequency allows you to focus in more closely, and then the STC adjustment can refine the image even better in terms of within this area of interest. Just out of curiosity, what do you think black hair is? Anybody? Fluid, exactly. So this looks like ascites, right? Okay. So frequency, basically, it's important to recognize that there are differences based on the scopes. The linears go from 5 to 12. They come standard at 7.5. They can go up to 10, and then the radial can also go, I believe it goes up to 12, right? On the Olympus, I think it goes up to 12 and a half, 12. And then the mini probes are the ones that really allow you to see very closely at mucosal lesions. And there you can adjust the frequency based on the lesion. With the radial, you can also split your image, so you can do upper half of the probe, lower half of the probe, or you can have the entire circumferential probe, so you can make those adjustments. So this, by the way, some of these adjustments you can do on the main panel here, and some of them are on the LCD display. So for certain things like adjusting the size of the radial image, you would have to hit the button here and then go from there. The flow, there are different types of flow that I mentioned, but if you hit the flow button, you'll start seeing, and you can then actually focus in even more on the type of flow that you want. And so these are the different modes of flow, and I'll just skip over to these are the different types. You can have plain color, blue is flow away from you, red is towards you. You can have power flow, which actually based on the intensity of the signal changes the color. And then high flow actually is just their default highest quality flow with both the strength information as well as power flow. And then when you want to see you can adjust the gain on the flow, so your area of interest, to see if you're getting flow or not. It may be that you just need to increase the strength of the flow signal. And secondly, you can also have dual images where you have with and without flow. And they claim that you can do this if you're worried about vessels and FNA, but usually I just keep a single image. This is radial, of course, but usually I just keep a single image, and once I know where the vessel is, go trying to avoid the vessel, of course. And then the waveform allows you to see artery versus vein. The point here is that all these adjustments are available, and you should know that they exist. And anybody who's getting a new unit needs to really get the company representative to. I don't know if that works here. Does Olympus come into it or not? No. There has to. They have.
When I first bought this EUME2,
Yeah.
We were told that this was the second unit that flew out of Japan in this entire region. Okay, so, and they promised me that there would be somebody coming.
Yeah.
But when it comes to coming to Pakistan,
Yeah, then it becomes
the
an issue.
actual text, the Singapore guys,
Yeah.
they're not happy to come. And then they want you to go and spend time in Thailand or wherever.
No, that- I don't-
I don't have that much time.
Yeah, I don't think that's acceptable. I think one thing you can say is, firstly, so a lot of these are from their brochure, which is like a getting started brochure. But one has to be familiar with these concepts. And honestly, even though my Olympus EUS specialist sent me that, I set up a meeting. I said, I understand you've sent me this, but we need to sit one-on-one and actually go through this. When I did this talk, when I prepared this last year. The other thing is, in today's day and age, even if they can't come, they should be able to do it, like FaceTime or something, that they actually can point out things on their machine, your machine, and actually do it live. There is no reason why, when they're providing this equipment, I think in America, because of various reasons, the wider availability, but pressures from the physicians, they really want to try and make sure that we don't get very upset. They provide the service.
I think during the course, you will certainly get an opportunity to understand these. You will be using some of them, the ones that are commonly used. And this will give you a good opportunity to actually ask where the actual technical usage is in the hands of people who do a lot of the EUS. The difference between those guys coming and obviously the guys that are using, there is a difference. So the emphasis is going to be on things that are relevant and more useful.
Yeah.
When it comes from people who are using it.
And there are a lot of features that we hardly ever use. I think for instance, though, the pulse wave I find very helpful when I'm looking at vessels, and I'm like, oh, is this an artery or a vein? I can't tell. Either way, you're not going to put a needle in it, but it's just like, it's more like if I'm trying to get a sense for, oh, there's tumor involving this, is this an artery or vein? Then it makes a difference. But realistically, in staging, maybe CTs, that's a different argument altogether, but it can be helpful. It's good to know and not use it than not know that it's there and never have the
Mustafa,
ability.
do you know how to measure the resistance when you are on an artery, like looking for any stenosis?
I personally don't ever do
I
it.
used to do, but I forgot. I'm just
On
asking
this
because I
one,
don't remember.
No, honestly,
Okay.
I don't.
'Cause, you can look at the SMA.
Yeah.
No, I have I used to do a lot actually when I started
I think one
the
of your
training.
mentors was quite
Yeah,
into
he's
it,
so
yeah.
very much into that. Mike Wallace is,
Yeah.
and we used to take a look at SMA, take a look at celiac, look for any stenosis. You
Yeah.
can check the velocities, resistance. So you don't have to send them for a Doppler. I just after this machine came, I just forgot. I stopped
Yeah.
doing that, and I thought maybe
No,
that.
I unfortunately don't, but I would.
I'm so glad there's one thing less.
I was going to say that, to be fair, I'll put it in the same category as elastography and.
No.
So I'm going to be fair. I'm
this
not going to
is-
have favorites. England versus America. I'm just. I'm trying to be fair here. I'm saying
No,
that
this is useful. Don't put it there,
Okay.
please.
no. Doppler is definitely useful, but
remember how you
but
Because I depend on the radiologist now.
But to what extent is it useful measuring an SMA per SMA syndrome, which half the time we don't know if it's really there or not. It's a different sort of issue. So, okay. So once you have the flow on, you're like, man, I can't even tell what's going on. So there are subtle things. So power volume adjustment, it's important because if you want to know, like, is this an arterial waveform or sound, then you just look for these buttons and you can actually put them on. But unless you know how to look for these volume buttons, you won't be able to adjust. And the other thing is, depending on the size of the vessel, the sampling volume has to be changed. If it's too big compared to the vessel, you won't get anything. It has to be within the walls of the vessel to actually get your flow pattern going. And then you have other buttons. I think this is probably one of the most useful ones, the caliper. This is to measure the size of your node, your mass, whatever it is. Picture in picture, this is good. Obviously, allows you to have two images. And then if you make a comment, you can type, or you have presets that you can select, but you mistype, you can always clear it. Doesn't, we don't have to have spelling mistakes in our reports, though it's not uncommon. Okay, so that's just a quick, brief sort of thing about the panel. I think we'll go over it more and more as we go along. So familiarity with scopes is really important. I think this is nothing like what you use in upper endoscopy, colonoscopy, or ERCP. And subtle differences make a huge difference as you're handling the scope. So this is a regular EGD scope. This is the radial. You have a circumferential ultrasound probe. And this is the linear head-on as well as the side view. You have obviously, so this is the ultrasound probe. This is the working channel with an elevator similar to ERCP. So that allows you to do the sampling or therapy. And then you have the camera and the light source. So that's on the linear. As far as the radial is concerned, the camera is, I'm not sure if it's visualized here. I think it's on the other side. But there is a gap. So the important thing to realize is your endoscopic view is about 1.5 centimeters to 2 centimeters away from the tip of your probe. And I'll show you in a second the differences in the different scopes when it comes to the ultrasound probes. The other thing is the bending section and the diameter of the scope. So this is an upper endoscope, 9.8 millimeters, and here's your bending section. I didn't measure it, but you can see this line, right? This is your radial, and it's at 11.8. And you can see that as soon as you get to EUS scopes, your bending section gets much longer. So this is important in strictures. It's important in D1 to D2 transition because this is what causes problems. This is how people get perforations, not realizing. And look at this. This is not rounded. The radial is pretty flat at the front, and that can cause problems. The linear on the Olympus is rounded, so it gives you some security. But interestingly, when you look at the brochures on these scopes, they'll mention outer diameter at the tip, which is 12.6. But as you see, it widens to 14 millimeters here. That's a big diameter. So if you're going through a stricture in the esophagus with a linear and you're having resistance, what will happen is this will get wedged in the stricture, and then you're pushing, and this is bigger, and all of a sudden there's going to be a give as this pushes through the stricture and causes a perforation. So if the scope is not going through, please stop. That's the one message with these scopes. This is not your head-on view. Even with the radial, it's not a head-on view. You have distance. So if you're getting resistance, stop, pull out, put in an EGD scope, and then go from there. Were you going to say something, Khalid?
Yeah, I was just going to say, a lot of you have done the ERCP scope. So this linear is bigger than the
Yes,
ERCP
it's a
scope.
bigger
So just,
scope.
Sometimes we may not be able to pass the linear scope, but ERCP scope
Goes through.
because that's the less than 12 millimeter.
Exactly.
So
Yeah.
just-
And the other thing is the differences in the different brands. So this is Olympus rounded at the tip. This is Pentax. Their ultrasound probe is bigger. So the images actually you get are different. They're both high quality images. Pentax images are actually very, very nice. But the one thing I would show you sort of on a lateral comparison is two things. One is this tip is not rounded. You see this is a rounded tip. This is a sharpish tip. And this, I think a lot of people struggle in. Oftentimes I'll tell my fellow that if you have any resistance, with this in the bulb, you need to stop and hand me the scope because this is what's going to cause the perforation. And then I'll try and then I'll stop or I'll get through. And this, the other thing is the bending section. You see how long this is compared to the Olympus? And these are not necessarily taken in the same plane, but the point is that there is a difference. I have the, in quotes, fortune of working with both brands. At one hospital I have Pentax, at the other I have Olympus. I had Pentax, but I insisted that they need to switch to Olympus. But in a way, my fellows and I both get to work with both and appreciate the differences.
So when we train on Olympus.
Yeah.
The maneuverability of the Olympus scopes are much
Oh,
more easier,
absolutely.
and they have shorter nose, you're less likely to cause problems. On the other side, we have the Pentax, that's usually me and my colleagues.
Exactly. I think the
Training, I think, so if you do one setup, I think, I haven't got any permission from Olympus, but I think Olympus is really nice.
And I think that this is where Dr. Gass's point is so important that the people who are making the decisions don't know these subtle things. So if you get a quote with Pentax, which has all the high features, and it's cheaper than Olympus's quote with all the high features, that can go in, that can make it be a disadvantage for you. But if you ask Olympus, listen, I don't want your fancy stuff, give me your basic equipment quote, and that ends up being cheaper than, and then ask Olympus for Pentax for your full package, right? Say Pentax, I want everything, Olympus, I want nothing. And if you can beat the price that way, then it may be better, because the problem is Pentax always undercuts Olympus in terms of price, and that's, and I have nothing against either. I mean, you know,
The new Pentax scope is being claimed to be
it's, yeah,
it's thinner and it's much better. I haven't seen it, but I'm told by the Pentax people here that's right above.
yeah. It's not only that, the other problem is it's too flimsy. So they've gone from, they've gone from one extreme to the other, because when you get into the second portion, it's not stable.
Okay, I'll tell you, I've used Fusionon,
Yeah.
and the best scope that I have used is Fusionon.
Okay.
But the pictures of Fusionon are not as good as Olympus. So the scope handling and everything else is really, really good. And the lobology is much simple as well. They've got everything there. But I found their images not as good as Olympus or Pentax.
Yeah.
But the scope is amazing. The Fusionon scope is really, really good. But for Pakistan, I personally feel, to be honest, I'm sure Riaz would agree, that Olympus for now, at the moment, the scopes that are available, this EUME2 probably works out
I
better.
think it's a lot of differences.
मैं वही पॉइंट कि जैसे डॉक्टर लुबना ने कहा कि उन्होंने जब स्टार्ट किया तो शी फाउंड इट डिफिकल्ट टू इंटरप्रेट चीज़ है कि व्हेनेवर यू आर स्टार्टिंग विद अ न्यू थिंग ऑब्वियसली
Yeah.
you have some difficulty and getting used to a new instrument always takes time. लेकिन बात वही है कि if you're exposed to three systems, अगर मुझसे पूछे तो the easiest tip to handle is जैसे साथ ने कहा कि फ्यूजी की है, और फ्यूजी का जो नया सिस्टम सोनाट उसकी जो रेजोल्यूशन है मतलब वो इसी तरह जैसे आप कह लें कि आपके जो तीन जो टॉप ऑफ द लाइन मॉडल्स हैं हैंडफोन के सेल फोन के, तो बाय एंड लार्ज दे कंपेरेबल टू ईच अदर
Yeah.
with few differences here and there. So it's exactly the same
Yeah.
in these endoscopes as well, in these three endoscopy systems as well. But the most important thing is कि आप किस से अपने आप को familiarize कर लेते हैं, किस पे आप comfortable हो जाते हैं, और कौन सी कंपनी जो कि आपको बेहतर बैकअप सर्विसेज देती है. Towards the end of the day, let me tell you, the main difference which is going to bring to your service is the backup service. If the backup service of X company is better as compared to Y and Z company, तो मैं ये कहूँगा कि go for the X company and not for the Y and Z company, क्योंकि ये वो instruments हैं which are likely to break down as you are using them, and their repair is very very expensive, and unless the company is very supportive, आपको मसले रहेंगे.
ये obviously बात है कि we are not trying to be a sales company.
Yeah, absolutely.
One other point, if I may add, with the repair thing, whichever company you go for, EUS scope, once it breaks, they have to send it.
Yeah.
They cannot repair it here. So you have to be, that is another reason why I feel that, you need to be very careful using it. If you have one scope, I think it should be used very, very carefully because it's
Yeah,
when it goes for 2 months. Therapeutic cases or EUS as well?
It's- so that would be considered diagnostic.
We consider
So
FNA and
it's a
FNB diagnostic.
diagnostic. So
When
anything.
sorry.
No, please go ahead. No, anything where you're looking and acquiring tissue falls in the realm of diagnostic. When we say therapeutic, we're talking about interventions for pseudocysts, bile duct access, any kind of stent placement. That is considered therapeutic EUS. Yeah. Yeah. So. Yeah. Yes, well, our practice in the Western sort of hemisphere generally has moved towards all anesthesia-supported cases, anesthesia-supported sedation for EUS ERCP. So, yeah, yes, no,
Okay, in my practice, I use, for most patients that are classed as diagnostic, most of them will have midazolam, usually 2 milligrams. Midazolam and 2, huh? This is amazing. Once you've intubated, I don't know why, and maybe once you've intubated the patient doesn't do anything in 9 or 10 patients. And I'm talking about minimal midazolam also. I use 2 milligrams midazolam and 2 milligrams skins, max 3. Okay, and they tolerate it by and large very well. Now the thing is, the reason why it becomes easy is that if the patient does not, then you have the option of bringing him next day and do it under propofol. And we have that option here that I have anesthetist anyway, so I will start and if I'm stuck, they will come and take care of it. But if you're doing it this way, then your numbers are going to be more, in my opinion. It's easier. Obviously, if you're giving propofol yourself in your unit, that's a different thing. I don't deal with that at all. So that our turnaround time becomes slow when we use propofol. That's one of the negatives for us, but it makes it easy. It's all therapeutic procedures, obviously. I wouldn't even dream about, think about doing them without proper anesthetic cover. But all FNAs and diagnostics, if you're doing it before diagnostics, in our unit first are attempted with midazolam and.
Yeah, I think there are patient population differences. We used to do conscious sedation, but our midazolam doses were in like 6 to 8 range, so much higher doses. Yeah, exactly. Yeah.
Our tolerance, the patients here tolerate it. I don't know.
Yeah, I think it's just patient.
No, for us, yeah, it's for us, it's not.
If you go gentle, then there should be no problem.
Yeah.
We have to be gentle, and the other point in incubation, I'm sure that's going to come again, is and with these guys there, I personally make sure that the neck is not flexed. That makes it easy. But this is, if the tip is long and bending, so I feel just a straight
Neutral
rather than
position,
the
yeah.
way we flex our patients for endoscopy. I don't, they're in straight, their neck is straight, and then we start, and it's very easy to go.
It's a very good point. People with high Malan-Barkley scores, I actually sometimes extend their neck and then bring it back to the neutral position.
Yeah.
If they're high, big patients, you will find it. So I will extend their neck, and as I get them to neutral position.
So basically, you can get all the specifics from the yeah. Let's just quickly wrap this up. So this is important though. You need to know the dials, right? So this is just a few short videos that I made just to know the terminology. So I was trained with big wheel up, big wheel down. Sometimes that gets confusing for people. To be fair, on the scope, it does say up and down, U and D. But it's just sometimes easier for trainees to just say, towards you or away from you. I think it's easier for early on starting out. But the important thing is it does, extend and flex a fair amount. So you have to be careful with your movements because what you do is going to be transmitted inside the patient with a bigger scope. The same goes with the left and right. Towards you, away from you, which towards you would be left, away from you would be right, and you can see that you can make adjustments. The other thing is holding the scope. This is my preference, similar to ERCP. Usually 2 fingers here, the index finger for the suction and water, air insufflation, and the thumb. My hands are bigger, so I can actually get my thumb across. If you have a hard time with the small wheel, you can always use the right hand on the small wheel. Though this allows me to keep my right hand available for the scope or my maneuvering, and left hand on the scope. And these somehow show upside down, but then they play the right way. I don't know why. And the other thing is important is movement fluidity is key. You're just supporting it. You're not holding it tight. You're not necessarily, you're not gripping it. You have to be allowed. This is a very dynamic procedure. You have to be able to get into the right position. And once you're there, allow your probe to do the work by using your hands. And if you look at my hands, you can do a 360-degree turn without having to go too far one way or the other, about 180 degrees, simply by using your wrist extension flexion and your shoulders going, extension and rotation both ways. And the other thing is, if you hold it too tight, then you're doing all this work and you're having too many turns, but the tip isn't doing much because you are holding it tight here, and so that allows the scope not to move freely. So that, and the other thing is the elevator, similar to ERCP. You have a working elevator which allows you to angle your needle based on the lesion. You can angle it and take tissue as needed. And then one last thing is stability of the scope. When you're using your needle for any reason, you can lock the big wheel. You see it locking it into position, and then you use your elevator. So if every time you look at the lesion and you go for your elevator, the wheel sort of, the probe moves away, it's okay to lock it depending on where you are, and then you can, in most situations, and then you can use your elevator. Here's one thing I just want to say, this is a subtle thing, but I want to show you. As I lock it, after I lock it, you'll see that there's a bit of retraction back. You see how the wheel just goes back a bit? So sometimes you need a lot of flexion, and you can actually use your thumb for both the elevator and the big wheel simultaneously to get that extra angle downwards. Those are little things with tissue acquisition or access that can help. So that's that on knobs, buttons, and the scopes. Any other questions? Okay, are we going to move on, or is it case?
I think we're going to move on. One thing about the images, just a few points.
Yeah.
The penetration of EUS image when it is really up to 6 centimeter. Beyond that, you're not going to find anything. You can make the image smaller, and there's going to be what we call a noise. It's a lot of noise. So if something is really more than 6 centimeter away, you're not going to get a good image on that. So just not try that. The best image is up to 4 centimeter. Even up to 6 centimeter is pretty good. And beyond that, that's about the penetration. Second thing is we're talking about, again, I'm going to say we're not a salesperson for the scopes. We're talking about the tip a lot. But if you look at the handle, that's the thing. If you look at the handle of all the scopes, the best functionality, what works for me, is like everybody is different, is with the Olympus handle, because that is lighter. And I can easily hold that when you have to do 10 procedures in a day, similar. So you don't want a very heavy scope and get tired, a longer procedure with that. With the Pentax, it's a quite heavy handle. And so that affects the functionality of the scope. So you have to pick between, you have to compromise on certain things,
Olympus, the image, EUS image may not be the best. It may be much better on Pentax, but what's the functionality of the scope? So I don't have much experience with the Fuji. Only time I have used is in your unit, but I think that's the old system, right? Yeah, so I can't comment on that really on the new one. And you have seen the new Pentax scope, but I have not.
Yeah, no, I had issues with it because now they've gone too far. Firstly, it's a 7 French channel, so you can't do any therapeutics with it. You can do needle FNA, but you can't do 10 French devices. Yeah, the slim line. And then the second is it's a bit too thin where it becomes floppy getting through the pylorus. And the second portion view is actually, in my opinion, not as easy. I tried it. I didn't use it in a large number of cases.
So if with the Pentax, because the probe, the distal end where the transducer is quite bigger, so people have a problem with the intubation.
Yeah.
It can become easier when you put the scope, inflate the balloon on that. So when that touches the UES, upper esophageal sphincter, patients swallow that. So it becomes intubation becomes a little easier when the balloon is inflated on that. So the one who have a Pentax system, they can try that.
Yeah, and also the bulb to second portion transition, if you put the balloon up, then you can have some cushioning as you try and turn around the sweep. So that's a very important point. So are we cases or are we carrying on?
We're going to do this normal and optimal.
Okay.
And then I'm going to
Do your thing?
talk a little bit
Okay.
about the stations and then
Okay.
On a lighter note, जब खालिद ने मुझे सिखाया था तो उस वक्त डिस्टेंस था 5 सेंटीमीटर. With the years,
4 and 6, I said. So.
So the normal anatomy, this is challenging for many reasons. It's not, there isn't much published on it. It requires ultrasound interpretation, and as we were discussing earlier, this is new to us as a gastroenterologist. We're not radiologists. The scope movement and different planes change with the orientation of the structures, but the image always defaults to one particular sort of setting, and that's the challenging part, that it doesn't move with the scope. That image stays fixed in terms of its orientation. So your scope can only move like 2 centimeters, and all of a sudden everything is flipped because it's showing you the same thing with the same orientation. And then you have variables, hiatal hernias, anatomic variations, obesity, different things will make what should be reproducible every time not so reproducible. Cross-sectional imaging, as much as we like to look at it to try and figure out what's going on, does not correlate with the EUS. That's with a non-distended stomach. The planes are different. It just doesn't correlate as well. However, I will say that it's very important when you're doing procedures. The best way to try and understand where to find your lesion when it looks a bit challenging or not is to look at the cross-sectional imaging before you go in there. So obviously the areas evaluated are wherever the scope can get us, right? So you can have intraluminal evaluation, so whatever the area you are in esophagus, stomach, you can evaluate the walls and lesions within or just outside the wall. And then you have the extraluminal structures that we all know about: pancreas, biliary system, liver, lymph nodes, etc. And as we all know, lymph nodes generally follow arterial structures. So if you can see an artery, you can follow the nodes in that region. But I will be honest, gastrohepatic and periceliac and all those all kind of become one in some, and then I say to my fellow, just say abdominal lymph nodes were seen. So sometimes it's so confusing. Lymphoma patients like, I don't know where this node exactly is. It's very large, but it can be sometimes very challenging. But again, correlation with imaging can help. So the basic 5 layers we should all be familiar with. So layer 1 is the interface between the mucosal surface and the luminal contents. Then you have the muscularis mucosa, which is the darker layer. Then you have the submucosal bright layer, and then muscularis propria. And depending on where you have the adventitia and the esophagus or serosal layers. The easiest way that I just, I used to somehow, it took me a while to get these down, but in the end I said 2 and 4 are muscle, and I'll just figure it out from there, and that seems to help. I just trying to keep it really simple. Then you can go one way and then the other way. Mediastinum, basically you're evaluating through this esophagus a few features. Because the lumen is small of the esophagus, and we're in the middle of the chest, it actually is the most reproducible, especially on EUS images, to cross-sectional imaging like CT. Linear can be confusing, but it's still easier to understand. And I'm going to show you hopefully something that will help you understand that. And the areas that we can see are, of course, the aorta, the branches, the pulmonary artery vein, azygos, heart chambers, lymph nodes. So all these like vascular structures that are nice to visualize, but also have lymph nodes around them that you can see. The one thing is anterior mediastinum we cannot see because we have the trachea. So air gets in the way, we cannot get the signal to transmit. And left side, because the esophagus is slightly to the left of midline, is easier to see than the right side. Right-sided nodes close to the esophagus should be visible in most cases. You just have to look at the cross-sectional imaging to understand where. But here's just some examples of correlation. So one thing to remember is that the esophagus is posterior to the trachea. So this is where we are. This is CT, aorta, and then azygos vein, and then trachea in the front. I tend to actually, people do this differently in different ways. I tend to, when I hardly ever use a radial other than for esophageal staging. But when I do it, I actually bring the spine at 6 o'clock to try and make it more like an CT cross-sectional image. It just makes it easier for the mind to process, right? Yeah, exactly. That you can say, listen, this is your CT, we're going to make it exactly like the CT and see if we can follow that. So, and then as you move down further, you can see the branching of the trachea into the left and right main bronchi, aorta, and then the azygos vein. So realistically though, we hardly ever use that. Mostly we use the linear. And what I did for this last year was that I actually had a patient, an elderly patient who was getting an EUS ERCP, and radiation wasn't really that big a deal. So during my EUS, I took pictures of my scope at the different stations to try and show you correlation. So you have the linear here, you have the probe facing somewhat posteriorly towards the spine, and then these arrows, so if it's coming this way, is basically going to the left or counterclockwise. Clockwise, and then if you're going right, which is going that way, that's counterclockwise. So when you're going down the middle of the esophagus, you have, this is a sagittal view, you have the pulmonary artery, left atrium, and the left ventricle further anteriorly, and you get this view. So this all can be somewhat challenging to sort of all appreciate together, but if you switch your EUS image like this, so you're looking down. Again, one thing I forgot to mention, the dot here represents towards the head end and the image. So basically this end of the probe, and then distal would be this side. So the dot is towards the proximal end of the probe. So if you flip the image, just turn it sideways, you can see as the probe comes down, we've gone slightly clockwise or towards the left. You have aorta, pulmonary artery, left atrium, and then left ventricle behind. And if you spin your scope here, you'll see more or less of the left ventricle. And then when you pull back and go down, you can see lymph nodes. This, I can just tell you that even having made this talk and having looked at it a year later, I had to focus my brain to completely understand it. So these principles have become much easier to understand once you're actually doing the cases. Other views that you get as you go along the descending aorta, you get a reflection of the aorta into the lungs. You can get the left atrium ventricle, which I showed earlier. This you have the right pulmonary artery, aortic valve, and then ascending aorta. And then if you go more to the right, you can see left atrium and you can see IVC. The point is you can see a lot of vascular structures. They're more really to help identify lymph nodes in those areas. So if you pull back here slightly, you will have the subcarinal region for lymph nodes. And if you come more proximal, if you pull back more and look more to the left, you have the aorta. This is relatively easy to understand. You're looking to the left, you have the aorta at the top, pulmonary artery at the bottom, this big arrow means that this is the way your probe is looking. And so you're looking through here, and you have, this is what's called the aortopulmonary window. The actual aortopulmonary window is this window. This is level 5, and this is level 4L for lymph nodes. So you will often see lymph nodes here, you may see lymph nodes here, and then 7, which is the subcarina, is where we were looking earlier. So these are some mediastinal views. As you advance, this overlaps a bit with Khalid's talk too, but just briefly, as you advance across the diaphragm into the stomach, there has to be movement to identify your structures, and usually at that point, once you identify your structures, there's more movement sort of counter and clockwise as opposed to pulling and pushing the scope too much. You find your areas of interest as you follow the aorta down. As you come across, you'll have the crust of the diaphragm, you'll have the celiac taking off, you'll have the SMA taking off. So this is a correlate on CT, celiac SMA, and this is in a human cadaver specimen, aorta, celiac SMA coming off. You have the pancreas in this view, which here we're not seeing, but it's telling you that it's close by. So once you have that, as you go towards the patient's left, then you're going towards, you see, if you go towards left, tail of pancreas, spleen, and if you go towards the patient's right, you're going towards head of pancreas, liver. So as you go towards the left, you will see various structures. This is so 2 CT correlates, sagittal and cross-sectional, but they don't really correlate. But this is your left adrenal gland. It's about here. And as you go towards the left, you can see the left adrenal gland. This is after you found it. It doesn't just come into view. You have to look for it. But this letting you know that this is what happens fluoroscopically to the scope once you find the left adrenal.
Can you, identify the crust of diaphragm?
How do you identify it?
Diaphragm.
As you come down from the esophagus across the GE junction, the first dark structure typically is the crust of the diaphragm.
Yes, and we'll see that in live.
Yeah, we'll show it to you in live
We'll
cases.
show it in
Yeah.
live cases too. But it's right above the ceiling.
Celiac, yeah.
You see that dark, kind of a triangular.
Yeah.
area? That's the.
It's a lot of repetition. You just keep doing it, seeing it, and then you know that this is what it is. So if you keep turning left, then you will basically eventually reach the spleen, and with the splenic vein. And this is a cross-sectional image in a human cadaver. But the point is, so understanding that we're not moving too much in terms of our scope position. All we're doing is staying in this region, and we're turning left, and we're seeing all these different structures. And this is where we are. And if you think about it in the patient fluoroscopically, then as we start turning towards the right, to the patient's right, we'll start seeing going the other way, and we'll start seeing the pancreas. Here you'll see the pancreatic duct, the splenic artery, and the splenic vein. And here basically we're in the stomach looking down on the pancreas. This is their splenic artery, splenic vein. Okay? And as you keep turning more to the right, relatively in that same area, you may actually see the pancreas dipping down. The other alternative, basically in the PD coming down this way, and then you see the confluence of the splenic vein and superior mesenteric artery. So if you look at the CT correlate, it's really hard to appreciate that because the stomach is not distended. Your scope is not here. It's just deeper inside. So this is just to give you a sense. This is, I think, more useful to know what's going on with your scope than looking at a CT scan. One thing is if you then advance more and get to the other side of the spine, then you can see now what you've done is you've advanced your scope and you're still looking down, and here the CT correlate makes a bit more sense. You see the SMV going down, so that's the SMV going this way, and you have the SMA here as well, and you can see potentially the rest of the head of the pancreas. You see the distal bile duct coming down from there, down into the head of the pancreas and the pancreatic duct. I can tell you that if anybody claims that they understand all this at this stage, that would just not be possible because it requires just repetition, but at the same time I have to give this talk on anatomy that you just to give you a sense for what really is going on with your scope. The main point I'm trying to make is that little movements change your views drastically, but you get a full evaluation relatively stable from one area of a lot of structures. So one thing you'll notice is that we'll say move your scope, get into position, and then look around as opposed to be back and forth, moving your scope left and right. Go ahead. So that's where the Doppler flows come in and repetition and recognizing the veins merging in the artery.
That's a
We'll
really good question, actually. If you look for the section, not only that, it depends how you are looking, which angle you are looking at the vessel. So you may be looking at the vessel, it's an artery, blood is coming towards the transducer. It's going to think it may be a vein or going a vein.
Yeah.
Like let's suppose if you're looking at I'm coming to that. Just give me a second. So when you look at that, so it could be blue, it could be red. You cannot differentiate. Okay, it's an artery or vein because it depends where the transducer position is. Are you looking from the top? Are you looking from the bottom? Because the transducer position keeps changing. That's where comes the power.
Yeah.
Power flow. So you can start that, and you get
The waveform.
waveform.
Yeah.
Venus waveform is going to be straight. I'll show that.
We'll show it to
When I
you.
do that live case, I'll show that. Venus waveform, it's a different sound. It's a constant sound. It's a different waveform. Arterial is a different waveform. So if you're just putting a Doppler on that, yes, you can't say 100%. You know that it is artery. I'm looking at the ceiling. I know that. So it is artery. But if I flip the transducer and it's looking from the other way, by color you cannot differentiate. Make sense?
Yeah, that's a very important point. The color it doesn't help
Color
us
is
much.
telling you
The,
it's a
the,
flow.
the pulse waveform is really what makes us tell. The other thing is with bigger arteries and veins, the wall slightly, artery is thicker. A vein will have a thinner wall. But the power flow is the key distinguishing feature that you have
Other
to.
is like when you look at the wall of the vessel, you can tell that to some extent.
Yeah.
Especially if it's a bigger. Again, it would be much easier to demonstrate in the live case. You can clearly see without a Doppler, if it's a bigger vessel, you can tell it's a vein or it's an artery by looking at it in black and white. So there is a way to do that.
Achha, Khalid bhai, I just wanted to add few points here. Differentiating between artery and vein, even without putting in any color Doppler on them. Number one, if you see the walls of the artery, there will be, if it's an old patient, you can clearly see calcification and intermedial thickening, and that can just correlate with the arterial wall. Number one. Number two is, if you look at the artery and vein and the flows within them without putting the Doppler, you will see that if it is a vein, it is going to give you some echoes of turbulent flow, like dirty water type feeling. In jo artery hogi, that will be pure in a quick flow, and so it will be pure, linear black structure, that is artery, and if you can see some flow or turbulence, that will be a vein. So even without putting color flow,
That's
If it's an aneurysm, it's going to be turbulence, but it's an artery. So it's there are too many things in there. Just even without putting a Doppler, Venus is going to be turbulence. It's an aneurysm in the artery, it's going to be turbulence.
सिंपल लफ्ज़ों में जो प्लेसमेंट में समझाता हूँ ये कि आर्टरी और वेन का डिफरेंस ये है कि आर्टरी ढीली होती है वेन ना होता है हमेशा आर्टरी जो है स्मार्टनेस रहेगी अंदर उसको नजर नहीं आएगा वॉल्स उसकी जरूरत ब्राइटनेस रहेगी बटन दबाएंगे तो शुक शुक की आवाज़
That's description.
Desi style, is it not?
And you can only describe that in Urdu.
That's quite the practical. Button the
Not button the button.
लेकिन हाँ वो हम भी बोले जा रहे थे तब से आपको ही कहते कि आप अच्छा so moving on to the bulb इसमें जो main thing you need to recognize is this is your scope position when you're in the bulb looking at the bile duct you're looking up towards the bile duct towards the patient's left and this I think CT actually correlates quite well you have the nearest structure to your probe will be your CBD which is this dark structure and then usually behind it is the portal vein and the artery is somewhere around here this is in a human cadaver again that's just that area magnified actually our scope is here our probe is looking up bile duct portal vein if you follow it up towards the liver you can see liver parenchyma as the portal vein goes into the liver and branches and if you come down this way you'll actually see the confluence of the SMV and the splenic vein and if you keep turning it you can actually come towards the head of the pancreas which is here and you can see the pancreatic duct too. So these are the movements of the bile duct towards the feet, towards the head. Towards the head would be to the turning your hand leftwards, and towards the feet would be turning your hand rightwards. And you can basically follow the bile duct all the way to the papilla in most of the cases. So this is a nice view. I really like following the bile duct throughout its extrahepatic biliary tree all the way from the hilum down to the head of the pancreas. Pancreas, exactly. Yep, exactly. Towards the feet is this way, and you'll see this is the towards the feet view. The bile duct and the pancreatic duct are coming together, and if you keep turning it towards the feet, you can actually see the two ducts merge at the papilla, and you'll see the duodenum down here. And as you go, I didn't show all the views, but as you go towards the head, we'll show this to you in live cases, then you'll see the bile duct turn into the liver, and you'll also see the gallbladder. And actually this next slide shows some of those views, but I'll skip that in the interest of time because that's what you'll see. And then the second portion, I know it's a challenge. I can tell you with my personal experience, even after my 1 year of fellowship, I was struggling with this. And what really made a difference for me was looking at other people's body position. I think that was a critical feature for me. We'll go through this in cases, but one of the tips I give to the patient, my students is, generally speaking, once you're in the second portion, you've reduced your scope. If you aim towards 2-3 o'clock, this way, the patient's laying here, and you're holding the scope like this, generally speaking, that's going to be your best position for second portion. If you're turned this way, your scope turns, and that doesn't allow you to do it as well. Khalid and you may have different approaches, but for me, this was the big change. I was getting to second portion, and like this, I couldn't find it. And I saw other people, and when they were doing it turned this way, all of a sudden the second portion became really easy for me. That's just a tip from my perspective. Everybody has different approaches. But here, when you're in second portion, you're looking straight across the pancreas towards the spine. And so this is the CT correlate looking across. And what you should see is the two ducts, the pancreatic duct and the bile duct. Of course, you have the aorta, IVC, you have other structures too. But oftentimes, we're focusing on the papilla, the pancreas. And then you can have lymph nodes in this area too. So this view, I think it takes longer to get. The easiest are the gastric views and the esophageal views. Bulb and second portion take more time. For some reason, I got the bulb quite easily, but my fellows, I'm having a hard time teaching it to my fellows. They always struggle in the bulb, and they get the second portion much quicker than I did, but they struggle with the bulb.
It gets busier.
Yeah.
You have to give them
Yeah.
the world becomes very busy.
You're busy, yeah. And there are fine adjustments that you have to make to get that cross-sectional CBD view. And then as you move the probe again, clockwise, counterclockwise, you can assess the pancreas, and Khaled has a very nice sort of demonstration of that, so I won't get into this too much. But as you change your views, angles on the scope, and you pull back, then you can follow the bile duct in its length, and so then you can see the ducts much cleaner. Incidentally, on this CT scan, not for you because this is too easy for you. Anybody like to point out a pathologic finding? Exactly. Very good. Yes. I actually saved it to show a stone in the CBD, but then I thought I could use it for this too. Okay. So main messages: don't lose hope. This talk probably confused you even more, but as you do more, it makes more sense, and you understand it. I'm more than happy to share these slides with all of you, just as a reference. But I think what helps is knowing fluoroscopically where the scope is to give you a better sense of what's going on in terms of the anatomy. Secondly, repetition is key. Case volume, which as you get your equipment, that'll happen. Reviewing imaging helps to identify pathology or where to target. When you're lost, well, this is where I should be looking to figure out where it is. But just remember, it does not correlate one-on-one with EUS, so that's an important thing. But general rule for EUS should be, if at all possible, review your cross-sectional imaging before you put the scope down. I mean, I'm very particular with my trainees on that, because if you're going in blind, you're literally going in blind. So this is not a test of you. At this point now, you're dealing with patient care, patient safety, and patient welfare. You want to test yourself, do it some other ways, but you should know what you're going for, target your exam based on that. So don't go in blindly. It's a dynamic procedure. Move around to recognize and identify structures, but then when it comes to it, you found them, then you have to slow down and study them. So there has to be purposeful movement, not haphazard movement. That's an important feature. Of course, sorry, this is like out of order, but if lost, vascular structures can be helpful to figure out where you need to go from where you are. And then utilize all sorts of resources, online videos, EUS books. The ASG actually has a very nice British DVD. I can't remember on ABCs of EUS. I can't remember where that guy's from, but he's actually done a very nice job. I don't know if you've ever seen that ASGE video on ABCs of linear EUS. Yeah. Yes. Yeah, it's very nice. It's actually very nicely done. So, and then review of cases. Actually, therapeutic cases help understand. If you look at videos of therapeutic cases, because you have fluoroscopy there too, it actually helps you understand the anatomy. So with that, I'll stop.
Books, online video library, and Boston's EduCare. बहुत अच्छी उसमें दी हुई है videos written on.
इसको मैं बस डिस्कनेक्ट. आपका कौन सा है? You have your own.
अमीर आदमी